Welcome to Tube. If you subscribe this channel, you can get updated, short and precise lectures on selected topics. So today we'll see on mediastinal goiter. We'll have outlines, we'll see introduction, definition, classification, pathogenesis, presentation, and management. This introduction, goiter is defined when there is anterior neck swelling due to enlargement of the thyroid gland associated with thyroid gland that is functioning properly or not. And the definition of substernal goiter is variable and unclear, and substernal goiter accounts around 10% of goiter and 5 to 6% of apparent mediastinal mass. Due to complexity of the surgical procedure and associated risks, management of mediastinal goiter is really challenging for the surgeon. When you see the principles of most, there are principles of most in substernal or retrosternal goiter. Almost all substernal goiter is arised from the cervical thyroid, and symptomatically most of the patient, clinically most of the patient are symptomatic. Pathologically most all are pathologically benign, and biochemically most of the substernal goiter are euthyroid, and diagnostically most are adequately diagnosed and evaluated by CT scan. And surgically almost all can be removed. Cervically and anatomically most of the substernal goiter are descend down to anterior and lateral to the trachea, and most of patients experience an improvement after from symptoms after surgery. When it comes to the definition of substernal goiter is less clear. There are various definitions given by different authors, and Kocher defines substernal goiter when an enlarging gland with some portion of remaining permanently retrosternal, and Torrey defines when the gland with its lower portion remaining below the sternal notch and hyperextended neck, and Krill defines gland with extension down to the aortic arch, and Linskog defines when the gland with its lower border reaching the lower transverse process of T4, and Catholic defines if greater than 50% of the great volume of the mass is present behind the sternum, and the recent definition given by Leahy, and it's defined when it requires mediastinal exploration and accession for removal, and Scarpas defines when the intrathoracic component appears extends 3 cm from the thoracic inlet. When you see the classification system, several authors have attempted to offer various classification systems for substernal or mediastinal goiter, and the first classification system is done by Leahy, and he classified based on the relationship to the aortic arch. He defined grade 1 when the mass extends nearly to the aortic arch, and grade 2 when it extends beyond or at or beyond the aortic arch. And Higgins classified substernal goiter based on the relative percentage of the mass in the neck or the chest, and he defined substernal when more than 50% is in the neck, and partially thoracic when 50 to 80% are in the thoracic cavity, and completely intrathoracic when greater than 80% is in the chest. Cohen and his colleagues also grade into 4 based on the percentage of intrathoracic component of the goiter, and grade 1 if around 25% is the chest cavity, and grade 2 26 to 50% is in the thoracic cavity, and grade 3 if 51 to 75% is in the thoracic cavity, and grade 4 if greater than 75% is in the thoracic cavity. When it comes to the pathogenesis, over 98% of substernal goiter is derived from caural migration of the cervical goiter, and there are a lot of contributing factors for this. The most important is the negative intrathoracic pressure generated by the swallowing and breathing mechanism, and also effect of the gravity and large potential space, because there is no anatomic structure that can limit the downward migration of the thyroid. The thyroid will grow down to the thoracic leg, which is less resistant site. And there are several theories on the pathogenesis of retrosternal goiter. The first is goiter develops from the thyrotymic congenital rest in the thyrotymic ligament, which usually appears after the surgery. And the second theory says it develops prologically from hyperdescent of the thyroid tissue, and the third is usually it is due to exophytic nodule grows down to the thoracic inlet from the inferior pole of the thyroid. When it comes to primary mediastinal goiter, which account around less than 1% of goiter, and there are terms used to describe this situation, including isolated goiter, ectopic goiter, heterotopic goiter, and aberrant mediastinal goiter. And when you say ectopic thyroid tissue can be found in the aortic root, in the pericardium, within cardiac muscle, or esophageal wall. And there is diagnostic criteria for primary mediastinal goiter, which usually defined if there is completely separate from the gland in the neck, if it has its own blood supply in the thoracic cavity, normal or completely absent cervical thyroid, no prior thyroid surgery, no current or previous invasive thyroid malignancy, and no similar pathologic process in the cervical area, the so-called the ectopic thyroid tissue. Clinical presentation: most of the patients present the fifth and sixth decade, and females are affected 3 to 4 times than the male, and around 30 to 40% of patients are asymptomatic, and no palpable mass is found in about 20% of the case, and 10 to 20% of patients may have prior history of the surgery, and some patients may present with arterial obstruction in acute manner. When you see symptomatic patients, more than 90% of patients will present with respiratory symptoms with cough, dyspnea, positional and nocturnal breathing difficulties, and around 1/3 of the patients will present with some degree of esophageal compression with dysphagia, and 10 to 26% of patients may present with hoarseness of voice with long-standing compression or the malignant infiltration of the recurrent laryngeal nerve, and around 10% of the patient may present with venous obstruction, and from this small percent of population may present with an acute manner with the superior vena cava syndrome. Investigation modalities include ultrasound. The significance of ultrasound in assessing the retrosternal goiter is limited because the bony thorax limits its visibility, but it can help to define the cervical extent of the disease, and also it's important to assess the parenchymal lesion. FNSA and thyroid function test is undertaken only if you have a concern with malignancy and toxic nodules. And just a X-ray and or neck X-ray. It's important to provide the first evidence of mediastinal mass, and it can suggest substandard thyroid in 60 to 90% of the case, but it is poor in correlating the imaging studies and the symptoms of the patient. On this image, you can see there is mass extending from the right side of the thyroid down to the mediastinum. CT scan, cross-sectional imaging study with CT and MRI provides the most important information for the evaluation and planning of the surgical approach in substernal goiter. In this image, you can see there is hyperdense, enhancing hyperdense mass as the thoracic inlet surrounding the trachea and compressing also the trachea. And on this image, you can see there is enhancing hyperdense mass extending originating from the right lobe of the thyroid and extend down to the mediastinum. MRI is very important because it will provide excellent information on relation between the great vessels and the mass, and it's also superior at detecting tracheal and esophageal invasion if there is malignancy. Direct laryngoscope is absolutely indicated if there is any history of hoarseness of voice and if we are concerned for vocal word function, and it can be done at the time of the surgery or post-operatively. At the time of the surgery, it is important to see the condition of the vocal cord and the position of the larynx, and post-operatively to review or to see the cord function. When you come to the management option, substernal or mediastinal goiter can be managed in this 3 ways. One is thyroid suppression, radioiodine therapy, and surgery. So thyroid suppression is generally ineffective and inappropriate, and the effect is usually modest, delayed, unpredictable, and durable. It's not commonly recommended. Thyroid radioiodine therapy is only indicated when surgery is contraindicated or precluded, and unlike the surgery, a full effect of radioiodine treatment is unpredictable and often not evident for the first 2 to 6 months, and it has a lot of complications, including around 5% of patients will develop thyroiditis, 20% of patients may need retreatment and or second treatment, and 60 to 100% of patients may develop hypothyroidism. Around 10% of the patients may develop radiation-induced Graves' disease. When you come to the surgery, the diagnosis of substernal goiter is an indication for the surgery because the patient will have associated increased risk of respiratory obstruction and also venous obstruction. But the surgery is remaining a great challenge for the operating surgeon because of a lot of factors, including distorted neck and base anatomy, restricted surgical access of the thoracic inlet, mediastinal extension of the mass, large size of the thyroid gland, and also increased vascularity, which usually needs skill. When you say the surgical intervention, the extent of the surgery is commonly bilateral total or knee total thyroidectomy, which has a low recurrence rate. But in some cases, if the swelling or the mass arises clearly from a single lobe, we can do unilateral surgeries, but it will have higher recurrence rate. When you see the surgical exposure, 97 to 99% of cervical, mediastinal goiter can be removed cervically, and the remaining 1 to 3% of patients may need another approach like partial upper sternotomy or simultaneous combined cervical and posterolateral thoracotomy approach. When you see the cervical approach, as we say, more than 97% can be removed cervically, and there are a lot of maneuvers that can be used. The first thing is you can fragment and you can evacuate the thyroid colloids, but this approach or this practice is recently not recommended by most experts because it is associated with increased in bleeding rate, and also it associated with spillage and also dissemination of malignant cells. And the other thing is you can drag, you can hold the thyroid tissue with your 2 hands and you can drag upward and you can remove, you can from the thoracic laser downward extended thyroid mass. And the other option is, if this failed, you can use partial upper sternotomy. This partial upper sternotomy has a lot of advantages than posterolateral approach. The first thing is we can extend so the cervical incision. The other is doesn't need repositioning of the patient, and it can give a clear view, a clear relationship between, you can see clearly the relationship between the mass and the great vessels, and also the recurrent laryngeal nerve injury, recurrent laryngeal nerve anatomy. But simultaneous combined cervical and also posterolateral thoracotomy approach will have increased risk of recurrent laryngeal nerve injury. Postoperatively, oral thyroid replacement should be given for the patient who are total thyroidectomy, and oral calcium carbonate supplementation should be given until the calcium status is known, because these types of patients have increased risk of parathyroid devascularization, so that we have to give until we know the calcium status. Postoperative complications, there are a lot of complications as you see in the list, but recurrent laryngeal nerve injury and hypoparathyroidism is a little bit higher than normal thyroidectomy procedures because of this distorted neck anatomy and also downward extended and narrow thoracic inlet. And the other complication is tracheomalacia. Due to long-standing compression of the trachea with the mass, the patient may have true tracheomalacia due to distraction of the tracheal ring, and the patient may have compression and deviation of the trachea. Patient having compression and deviation of the trachea, the compressed ring can return to the normal anatomic position within 24 to 48 hours, but the trachea shift may stay more than a month to return to the anatomic position. And around 2 to 13% of patients may need tracheostomy, emergency tracheostomy, due to long-standing compression and tracheal distraction, tracheal cartilage distraction. Other complications include bleeding, pneumothorax, wound infection, esophageal injury, Horner syndrome, mediastinal hematoma, chylus fistula, and pleural effusion. And the last is recurrence. When this is a recurrence, the long-term study report a recurrence rate of around 15 to 60%, and it's highly dependent on the extent of the surgery. I said patient having bilateral, near total, or total thyroidectomy have low rate of risk than patient having unilateral surgeries, and it can manifest after a long time, after 10 to 13 years, and it's more common in young female with family history of retrosternal goiter. And this type of patient, even aggressive treatment may be needed. If the patient develops recurrence, or radioactive iodine can be considered as a treatment option. So this is our reference. This is today's science of today's session. In the future, in the coming videos, I will bring you another challenging and important lecture notes or lecture videos. So don't forget to subscribe